بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا محمد وحبيبنا ومعلمنا وقدوتنا صلى الله عليه وسلم. اليوم إن شاء الله نتكلم عن موضوع مهم جدا، كيفية التعامل مع مريض زراعة الكلى قبل وبعد العملية جراحة زراعة الكلى مباشرة. Our topic today, first week after fresh kidney transplant, clinical intervention, what you will do or what you will intervene with your patient to enhance recovery and decrease or shorten the length of stay in hospital, especially in ICU, to shift the patient toward and then home. أولا بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. نبدأ اللهم صل على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. The first slide here, I just first do no harm. Don't do any harm for your patient by your intervention or your management. And we'll know that in next slides. First week after fresh kidney transplant, clinical intervention pearls to enhance recovery via Pre-Transplant surgery clinical pearls, and we'll talk in this in details. Optimize IV fluids for your patient, also we'll talk in details. And early mobilization, early progression of diet, optimization of time in critical care. Don't keep your patient critical care too much and limit his activity. This is our objective today. We'll discuss each in details. Pre-transplant surgery clinical pearl. Most important pearl prior surgery. Just when your patient came to do his surgery, during your admission, you will do CBC and routine labs, include lights and biochemistry and liver function test and INR, PTT, cardiac enzyme, troponin. Everything will do to be sure your patient is stable to undergo into his kidney transplant surgery. Cross match according to your protocol, just a routine cross match or a stat cross match. Already your patient living donor and he did already is match cross match before admission. Chest X-ray to rule out any chest infection. Many patients cancel because new chest X-ray finding. ECG also you should do to rule out any ischemic changes or arrhythmias. And prepare just pre-operative order, saline withdrawal plus antibiotic prophylaxis. To be prepared day before surgery or day of surgery for your patient to be taken during his surgery by an anesthesia doctor. Pre-transplant dialysis, if a patient came to your admission to your hospital or your transplant unit for transplant surgery, you should ask your patient what is the last dialysis for him and what is dialysis modality, either hemodialysis or peritoneal dialysis. You should arrange dialysis for your patient one day or night day of surgery. Especially whatever potassium 4, 4.5, better to arrange dialysis prior to surgery to stabilize his electrolyte and his uremic status and his uremic toxins also, to help the patient early recovery after surgery and avoid any need for dialysis post-surgery. We'll arrange dialysis especially for potassium 4.5 or 5, or the patient was due for dialysis according to his schedule. He should be dialyzed on day of admission or long period from admission to expected OR time. Aim for pre-operative weight. Just keep your target weight 0.5 to 1 kilogram above that target dry weight. Don't forget that to keep this good, to give a chance for good perfusion to kidney transplant graft after surgery. Keep your patient little bit hypervolemic. Don't take more fluid and keep the patient contracted or hypovolemic during the surgery. This will affect the perfusion to kidney transplant graft. Avoid heparin. Just you will do dialysis without heparin. If you are, will be immediately post dialysis. Please don't last dialysis before surgery. Do heparin free without heparin. Arrange peritoneal dialysis bicycler overnight if the patient admitted night of surgery, and just drain his peritoneal dialysis fluid 1 hour prior to surgery. Pre-transplant, what is worries you? Blood pressure in hemodialysis, blood pressure elevation in hemodialysis, too much ultrafiltration. Blood pressure dropping in hemodialysis, this will worry you or no? And this slide from Dr. Karim, that young age fresh start on antihypertensive This patient can tolerate more ultraviolet. If the patient hypertensive and already the patient received antihypertensive medication, please take fluid as you can. Just a message here, any patient hypertensive on dialysis, this volume overload or hypervolemia until proved otherwise. Take fluid as you can. This patient can tolerate to take much fluid. Take 3 liter, 4 liter, whatever the patient can take, you can take. High blood pressure before hemodialysis on antihypertensive medication, this patient no worry for that also. I am not worried for that. We can take more fluid for that also. Low blood pressure before hemodialysis, middle diabetes, cardiac, this is autonomic neuropathy here. And me cardiomyopathy, maybe cardiomyopathy also. Just I will worry for that patient. Just I will go gentle with him. We can take 1.52 liter like that. Low blood pressure before hemodialysis, tachycardia, even lower on hemodialysis. This means your patient with pericardial infusion, even pericardial effusion, even maybe cardiac tamponade. This is a criteria for that. Because the blood pressure, cardiac intravascular collapsing during ultrafiltration during dialysis with tachycardia and the low blood pressure, this criteria for cardiac tamponade. Blood pressure elevation, if the patient hypertension during dialysis, this means renin drive, the renin already the protein secreted by the kidneys, especially in response to hypovolemia or intravascular volume depletion, lead to more renin, and renin will activate angiotensin 1 and 2, and will end by aldosterone, salt and water retention, and it will end by blood pressure elevation on the hemodialysis, or high sodium pass on the machine, on the dialysis machine, or cool dialysate. This is the 3 main mechanism of blood pressure elevation on hemodialysis: either renin drive from hypovolemia from ultrafiltration, or high sodium pass in dialysate of dialysis, or cool dialysate will end by vasoconstriction. Too much ultrafiltration, anuric patient, non-compliance, drink a lot of fluid between session, high sodium on the machine with too much ultrafiltration, especially with anuric patient, drinking fluid a lot in between session, high salt on salt on the dialysate pass on the dialysis. This will end by too much fluid gain, and you can take ultrafiltration on this patient for the patient taking too much already. Immediate post-transplant management, when you will nurse will call you when the patient arrives to pack you to assess your patient after surgery. You will check number 1 vital signs and the clinical in general كده clinical patients. This patient already stable or agitated, confusion, delirium, agitated like that. This is the job of anesthesia to stabilize the patient and the good recovery for your patient. To stabilize your patient, this is number 1. Vital sign, blood pressure low or high, whatever. If you found your blood pressure 90, especially living recipient, you found the blood pressure less than 100, should give bolus normal sign to 150 or 500, and check, don't give too much fluid also, and wait until we'll see. And this is the blood pressure, check temperature also, and check your heart rate, check your respiratory rate, and chest X-ray, ECG, routine lab after transplant. All this should be checked in PACU, and dressing wound like that. You should check that all this, and you should decide to admit the patient to ICU or ward according to your program and facility. Your about does not guarantee a graft function, because some patient non-oliguric AKI, delayed graft function, or residual renal function if a small amount of urine output. Just to control your patient. If the patient in pain, you should have protocol for pain control. Intraoperative fluids also. You should know how much the patient received and how much the patient target weight now after surgery, and vital sign as I mentioned for you. Immediate post-transplant management, ensure adequate volume status by arterial line placed at time of surgery, and central venous line, CVB. Central venous catheter already should be done to check CVB. Aggressive fluid, especially patient will receive ATG or thymoglobulin. To be sure, if a patient not on central line before OR, you should ask anesthesia to put central line for ATG or thymoglobulin, which is difficult to be taken and complicated. Many complications happen if taking peripheral line. Aggressive fluid resuscitation if the patient hypotensive. Intraoperative echo to assess cardiac filling may be done. Avoiding nephrotoxin is ARPS, ammonia dioxide, non-steroidal like that. Immediate post-transplant management, early ultrasound if concerned, Doppler when I will ask for ultrasound immediate post-surgery, if I have living donor with no urine output. This is the most important, but a deceased donor, and the deceased donor, I'm not hurry, just will check maybe by according to the protocol. But if a patient living donor, you should immediate good urine output, maybe 1 liter, 2 liter, whatever, by hours. At least you have good amount per hour. But put in your mind if the patient have good residual renal function also. You should decide when you assess a patient in PACU. PACU is the recovery room after surgery. You should assess your patient in this recovery room, any Doppler stat or no, to rule out renal artery or veins thrombosis or stenosis. Don't forget about post-renal causes for any patient with no urine output. Just check the folic acid may be kinked or blocked by clots. No urine output post-surgery, folic acid may be obstructed, folic acid obstructed, urethral obstruction, no blood flow to transplanted kidney, hyperacute rejection. You should put all this in your mind. Just check folic acid, urethral obstruction, no blood flow to kidney by ultrasound, and hyperacute rejection. What's your action? Flush fully with saline to dislodge any clots, urgent Doppler ultrasound, call transplant surgeon. What's your action if no urine output, especially if living donor, flush fully with saline to dislodge any clots, urgent Doppler ultrasound, call transplant surgeon, especially with a living recipient. Watch for post-operative high potassium, insulin shift, Lasix. If urine if the kidney start to get urine, just use the kidney. Don't use the dialysis, please. If the patient with urine output, you can give 120 Lasix, 140, 180, 200, whatever. IV Lasix, just use the kidney. Don't use the dialysis machine. Better to use a transplanted kidney. And right, I will give Lasix 120 IV to drive to control hyperkalemia, not for hypervolemia. And some patient may be hypervolemia and a little bit of urine decrease from I think urine about 200 ml per hour and then drop to 50 ml per hour. You can use Lasix also for patient overweight, over his target weight already. Only dialysis if the patient is still refractory and the potassium increasing, the volume increase, and the kidney can't work rapidly. This patient with delayed graft function, severe ATNs, you can use dialysis, gentle dialysis, blood flow, whatever, dialysate flow, and decrease time, and without any ultrafiltration, without heparin. Don't forget, without any heparin, without any ultrafiltration. Just to especially except if the patient body overload pulmonary edema. Otherwise, don't ultrafiltrate any fluid. Just we are dialyzing for hyperkalemia. Your goal in 48 hours post-operative, maintain a slightly hypervolemic state to maintain kidney perfusion. This is your goal in 48 hours to keep your patient in hypervolemic state to maintain kidney perfusion. Target CVB around 10 centimeter water by replacing urine output 1:1 plus policies as needed. Always start replacement by half normal saline, then adjust at the urine lights. Better to continue your half normal saline because this is delayed graft function already, and the urine lights most of the patient with delayed graft function around the 80s, and half normal saline containing 77 for each liter, 77 millimole sodium for each liter of half normal saline. Follow-up serum urine lights, maybe according to your protocol, 6-8 hours. If with good urine output, follow serum and the urine lights every 4 hours. Normal saline policies, if a patient hypovolemia or hypotension only at that time. After 24 hours, replace half. After 24 hours, you'll change the replacement from 1:1, half to 1. Then once the patient tolerating LBO, you can stop IV fluid by post-operative day 2 or 3. A routine post-operative transplant should be done post-operative day 3. According to your protocol, some protocols post-operative day 3, some post-operative days 4, 5. And folic acid out by post-operative day 5, and other protocols by post-operative day 3, and another maybe prolonged 1 week, 2 weeks, 1 month, according to a surgical and urological problem in your patient. Delayed graft function, multiple definition. This patient need dialysis in the first week after surgery, either for hyperkalemia or hypervolemia. This means delayed graft function. Living donor is less with the living donor less than 5%. Deceased donor around 30 to 40%, around 50%. donation after cardiac death around 50%. Other risk factor: donor age, cold ischemia time, perioperative hypotension, and recipient vascular disease. All this risk factor for delayed graft function are donor age, elderly, more common. Cold ischemia time, more risk for delayed graft function, and the perioperative hypotension and recipient vascular disease. Post-transplant dialysis, avoid any hypotension, excessive fluid removal, or no ultrafiltration is better, and heparin-free. Otherwise, the patient will be bleed. The fresh surgery. BD can be done if the peritoneum not breached during transplant surgery. Ask surgeon, you breach your peritoneum or no. And the immunosuppression protocol, choice as an induction of your protocol and your plan. Pre-transplant surgery is patient high risk or low risk, will inducted by thymoglobulin or basiliximab, and will continue maintenance in tacrolimus, advagraph, Silcept, and Nifortic or versus azathioprine. Steroid regimen, standard protocol for each program. Each program have individual protocol. Consider patient medical history and comorbidities, immunological risk, and perioperative course. Post-transplant prophylaxis, don't forget that. Don't forget heparin. The DVT prophylaxis is the most important one. If the surgery is okay and no other issue from surgery, don't forget heparin or tinzaparin or whatever after surgery as a prophylaxis. And as regard to antifungal, nystatin, BGB already, the Theptradapson and atovaquone and pentamidine, CMV as we discussed before, valganciclovir according to mismatch, and GI protection by PBI or H2 blocker. Post-transplant antibiotic maybe 2 days, and especially if donor positive infection, urine or blood, whatever, according to your protocol. Patient came to emerge, fresh transplant came to emerge with fever and or whatever graft pain. You should think UTI, maybe pneumonia, maybe gastroenteritis, also diarrhea, AKI pre and renal and post, pre-renal, renal and post-renal. UTI often lead to graft pyelonephritis, fever, dysuria, tender graft, pneumonia, need spectrum antibiotic, early transplant ID and respirology culture sensitivity. Diarrhea often associated worsened by MMF, may need to reduce or hold for 48 hours. Don't forget CMV virus infection also. Delayed graft function, common causes of delayed graft function: pre-renal, renal, and post-renal. Pre-renal hypovolemia, post-operative complication, pulmonary embolism, MI, tacrolimus, CNI toxicity, whatever. Other medication, non-steroidal ACE inhibitors, renal artery embolus or thrombosis, renal venous or arterial thrombosis, post-ischemic reperfusion injury, ATN, hyperacute accelerated rejection, post-renal ureteric stricture, lymphocyte or urinoma or hematoma. What is the investigation will do if your delayed graft function? Assess your volume status, keep T9 level at the target, check pre-operative cross match, obtain transplant ultrasound Doppler and resistive index. Always do ultrasound and Doppler urgently if the patient anuric, especially with a living recipient. In disease or living donor, in disease consider transplant biopsy also. Management, ensure adequate effective circulatory volume, hold any nephrotoxic drugs if possible, reduce C9 level, address any specific post-renal complication or rejection. Acute renal failure in renal transplantation, common cause of week 1 to 12. The common cause of acute renal failure: acute rejection, acute allograft pyelonephritis, acute rejection, acute allograft pyelonephritis, and CNI toxicity, hypovolemia, urinary obstruction, ureteric stricture or fluid collection, CMV infection, recurrence of primary disease, for example, FSGS, focal segmental glomerulosclerosis, and atypical HUS. This is a common cause in the first weeks of acute graft failure or rising creatinine, either from rejection or pyelonephritis or CNI toxicity, hypovolemia, urinary obstruction, or CMV infection, recurrence of primary or de novo GN, or recurrence of primary disease, most common with the focal segmental and the atypical HUS. Common cause of graft dysfunction, more than 3 months, acute allograft pyelonephritis, hypovolemia, CNI, rejection, recurrence of primary disease, BK virus nephritis, post-transplant lymphoproliferative disorder, de novo of renal disease, more than 3 months post-transplant, more than 1 year, causes of renal allograft loss. This more than 1 year after transplant, chronic renal allograft dysfunction leading to graft failure in 50% of the cases. This of the patient with functional graft around 50% of the cases. Chronic allograft nephropathy in 30 to 40% of the cases through chronic rejection or chronic allograft nephropathy. And other diagnoses like chronic toxicity of CNI or recurrence disease or de novo disease or acute rejection, all this should be differential diagnosis. Investigation from history focus on the medication change, adherence of immunosuppression medication, history of CMV, ABV mismatch, or recent illness or volume loss. All this can lead to a graft dysfunction. Physical exam focus on the volume assessment, lab including urine electrolytes, urine depth microscopy, and sediment, serum, tacrolimus or cyclosporin level, and routine blood work, transplant ultrasound with Doppler. Causes of graft loss, as we know, this recipient with functional graft, either cardiovascular death or event or infection malignancy. This death of recipient with functional graft from cardiovascular event, infection, malignancy. And this number one. And number two, this is the most common cause. This of recipient with functional graft, this is the most common cause of graft loss. Rejection, number two, and recurrence disease, number three, recurrence of de novo primary gene or primary disease for the patient. Now, the main topic, the main clinical pearls in our topic today, how to enhance recovery after surgery pathway. ازاي تخلي المريض بتاعك ما يطولش في المستشفى وما يطولش في العنايه وما يطولش في الكير وما يكلفش المستشفى. ازاي هتمشي في الخطوات دي؟ الايم to minimize the pre-operative physiological dysfunction. This is iatrogenic from us or this is our mistake to keep your patient bedbound and keep the patient without diet and keep the patient after that he need physiotherapy and they will be handicapped. Aimed to minimize pre-operative physiological dysfunction and surgical stress response in order to promote quicker rehabilitation. Key element of our home message today into short length of stay and the cost. Optimization IV fluid. Maybe some patient paying from their pocket. You should shorten the length of stay. How to do that? Optimization of IV fluid, avoid unnecessary IV monitoring and IV fluid. Just I will give you now how you can deal with the IV fluid in post-transplant period and don't stay more than maximum 2 days with IV fluid. Early mobilization, you should know that, early mobilization from day 1 and sometimes maybe day 0 after morning after maybe 8 hours or 12 hours. Early mobilization, early progression of diet, optimization of time in critical care. Don't stay long. How to deal with IV fluid? On post-operative day 0, this means the day of surgery. And the day 1, this is the second day of surgery. Day of surgery, urinary replacement on day 0 for 24 hours only, just 1 cc to 1 cc, cc to cc urinary replacement by half normal saline. If a patient, for example, excrete 100 ml urine, you should replace this 100 ml half normal saline. Except if a patient hypotension, you can change it to normal saline temporarily. You know, the problem with normal saline, this will give you more saline, will give you more acids, will end by volume overload and metabolic acidosis. This is the issue for normal saline. And you know, your patient sometimes delayed graft function, just urinates with non-functional tubules around 80 to maximum 80 millimole sodium. Better have normal saline for that patient for any kidney transplant. Post-operative day 1, you can cut down the fluid to 50% of a replacement with half normal saline. If a patient bringing 100 ml per hour, I will give 50 ml per hour, half the replacement. And you can make it easy to your nurse if your nurse is not expert to maybe will give every 4 hours around 400 if the patient bringing 100 ml per hour. Post-operative day, from post-operative day 1, the patient should be drink and take an oral. Post-operative day 2, you should stop all. Some protocols given 75 ml per hour maintenance and other giving this urine replacement with 30 ml insensible loss at the replacement. We can use this if a patient aggressive polyuria with making urine around 5 to 10 liters per hour. You can keep this maintenance 30, 50, 75 according to your protocol. But if the patient is okay, don't use this maintenance fluid. And the post-operative day 2, you should wean your patient from IV fluid. Do no harm. First, do no harm. This is a Greek word already. Don't do harm for your patient. Volume status assessment, do no harm. 50 years male patient in this secondary focal segmental and peritoneal dialysis. Post-NDD kidney transplant, then neurological determined death or kidney donation after neurological death. And the patient's systolic blood pressure 150, 160. If you found your patient by this blood pressure, this patient hypervolemia. Don't give any more fluid if your urine output is low. You can give Lasix at that time. And just this patient, dyspnea on exertion, and the chest is clear, no lower limb edema. Dyspnea on exertion, and you can clarify this. Ask the patient to take deep inspiration and listen for a chest. You will find some crackles patient with this high blood pressure, even if no lower limb edema and chest X-ray is clean. This patient hypervolemic, don't give more fluid for this patient, okay? If especially if the patient with low urine output, no harm for your patient. Target weight, when you assess any patient in dialysis, target weight inaccurate or not true for most of our patients, because most of our patients sometimes came fresh dialysis or recently starting dialysis with hypertension 170, 180, and you decide to take each session maybe 2 to 3 liters of filtration. After the patient develop cramps, you decide to fix this target weight, but still the patient hypertensive. But this problem revealing maybe an autonomic problem. Just don't, any patient with hypertension, as I mentioned for you before, any hypertension, hemodialysis, this volume overload until proof otherwise. You should take more fluid until control your blood pressure. Because this target weight is subjective and it's challenging and it's complicated already. You should try to take more if the patient is cardiac status is okay and the patient is young and fresh dialysis and still severe hypertension on many polypharmacy for hypertension medication. You should take more fluid. Why do we this cardiac case with long-standing diabetes? Why we did this cardiac case with long-standing diabetes? Because it's high risk. Any patient with long-standing diabetes is high risk for post-operative complication with MI like that. Can you transplant transplant high-risk cardiac patient? Yes, because it's already transplant surgery is a minor procedure. Just will insert the kidney. The problem, but this immunosuppression sometimes you are giving more fluid. Some this related to volume overload. Otherwise, the issue for transplant with any cardiac problems is not this mild surgery or mild risk surgery, not high risk, mild to moderate risk surgery, especially patients with long-standing diabetes. But for us already, as regards KDIGO, if the patient without any exertional dyspnea or doing exercise without any problem and the patient looks healthy, no need to do angiography. But already to be in safe side, any patient with long-standing diabetes better to do because this patient will develop just painless silent angina or MI, better and maybe sudden arrest. Better to do coronary angio, and if you need a stent, you should both before surgery, and try to avoid any excessive fluid given for this patient. Is more strain on the heart, may will end by arrhythmia and cardiac arrest and bad end for your patient. What is the volume status do you prefer? When you send the patient to surgery, what is the volume status? For me, just I need my patient. You should measure your patient by central venous pressure, central venous line. Slightly hypervolemic, not EU or hypovolemic, especially CVB above 10, whatever. To maintain good perfusion to a transplanted kidney, do no harm, please. Because the patient of hypovolemic maybe will end by delayed graft function, severe retain. Another case, post-kidney transplant with systolic blood pressure 160, 170. When we see this blood pressure above 140, this patient means hypervolemic. And the patient already 40 to 60 kg above his target weight, urine dropping, decrease, only start to be oliguria. Folic acid already checked and no obstruction in the folic acid. What would you do next? Please, this blood pressure and above his target weight, try Lasix for that. I will give 120 milligram IV Lasix or 80 or whatever, 100, whatever Lasix IV to promote or induce more diuresis. Don't give boluses of fluid. Please do no harm for your patient. Other case, post-kidney transplant with history of coronary artery disease. just complaining of 1 week ago of severe gastroenteritis, diarrhea, and vomiting. Blood pressure he came a little bit soft, 160, target weight 2 kilogram, blew his target weight, and his hemoglobin 7.1. This is already elderly male patient, around 70 plus or 60 plus, and with history of coronary artery disease, and he came by severe gastroenteritis and blood pressure soft, and his target weight 2 kg, blew his target weight, and hemoglobin 7.1. What should you avoid for this patient? Rapid IV fluid boluses. You will give for this patient rapid IV fluid with this history of coronary artery disease and hemoglobin 7 and elderly male patient. Or what if you give 2 liter normal saline, 0.9% and 1 bagged red blood cells, the patient will go to ICU with pulmonary edema. For that, this is our expectation after you're giving this harm for your patient. You should treat this patient by first giving red blood cells, by 1 unit bagged red blood cells. Otherwise, your patient will go to congestive heart failure from anemia at least. Another case, post-deceased kidney transplant, post-operative day 2, systolic blood pressure 160, 170, also hypertension, hypervolemia with 4 to 6 kg above his target weight, and the urine started to be oliguria, folic acid checked, and no obstruction. He received 500 normal salines, in another 500 normal saline. You did now harm for your patient. And this 1 liter normal saline bolus now did atrial stretch from intravascular volume overload, and the patient runs into atrial fibrillation with rapid ventricular response. Other patient can develop MI if elderly age or coronary artery disease like our patient. Take care from that point. This patient with this blood pressure and this target weight, when decrease the urine about, no need for fluid, please, because otherwise the patient will be collapsed and will end by the cardiac dysrhythmia or MI. So started on diltiazem. This patient already started on diltiazem, hypotension, and the patient developed hypotension. You are giving more fluid, unable to ultrafiltrate despite hypervolemia, and the patient already ended by pulmonary edema and need urgent dialysis. And also, but from this diltiazem potential efficacy toxicity, because diltiazem inhibitor to cytochrome B450. This lead to tacrolimus toxicity, diltiazem, and this will end by delayed graft function from all this scenario, from hypotension and the CNI vasoconstriction will end by delayed graft function. For this patient, when came like that, please use Lasix in this patient. Why you don't think Lasix will help with more diuresis for your patient, more controlled blood pressure? This is volume-related hypertension already. Do no harm for your patient, Dr. Karim said. Some random policies. What is the end of this random policies? As mentioned by Dr. Karim also, this is more than 100 meeting, root cause analysis and the protocols, 100 meetings for extra, 100 meeting for extra left heart cardiac cath, 100 of 100,000 in ICU, 100 of $1,000 in ICUs from this random of policies, higher mortality and higher delayed graft function rates. All this is a complication by us, by our physician, heterogenic complication or harm to our kidney transplant recipient from this random policies from IV fluid. What is the issue for beta natriuretic peptide? This slide from Dr. Karim also. Beta natriuretic peptide potential marker for volume overload, but often non-specific. This is specific just beta natriuretic of more than 500. If less than 100 is not specific for volume overload. We increase our volume, intravascular volume, increase the myocardial stretch, increase the PNB and the natriuretic peptide. All this will end by decrease aldosterone, antidiuretic hormone, renin, and lead to kidney more natriuresis, diuresis, vasodilatation, and will end by decrease the blood pressure, hypotension. Don't be tricked by this PNB. PNB less than 100 rule out heart failure, and PNB more than 500 specific for heart failure. But the PNB you will find is high with elderly hypertension, female renal failure, decrease in obese on antihypertensive medication. Obese and the patient on antihypertensive medication, you will find PNB is low. What is the pearl now in fluid replacement? Post-kidney transplant, day 0, blood pressure 140/90, replace 1:1 urine output. What is the best IV fluid replacement? As I told you, half normal saline, and they can give 0.5 to 1.5 ampule by car to this fluid. It is the best solution or best fluid used forever by experience on post-transplant kidney transplant. Normal saline policies of hypotension only. I will use normal saline only if the patient has severe hypotension or blood pressure less than 100 or 90 like that. At that time, you can use bolus of normal saline, but the replacement, better to keep this half normal saline. And if your patient severe acidosis, you can add 0.5 or 1 ampules or 2 ampules to your half normal saline, because this equal urine output, especially in post-transplant with late graft function. From severity industry, urine sodium will found around 80s like that. Better to use half normal saline post surgery. And this here, as we mentioned, by replacement of fluid, this from handbook of kidney transplant by using half normal saline, because the urine sodium concentration in the early post-transplant is usually 60 to 80 milliequivalent per liter. This is the message here, to use half normal saline plus or minus by car. What happens if you replace with normal saline or ringer lactate? Ringer lactate, I prohibit that because it already contain potassium, and maybe I know this is isotonic. I can use any other not in the post-kidney transplant, because I know a small amount of potassium and a little bit lactate will change it to bicarb. That's a good fluid, isotonic fluid, but better to avoid, especially in post-anuric patient, post-diseased kidney transplant. Normal saline will add more salt and more acids to your patient. It will end by volume overload and metabolic acidosis. Just to remind you, normal saline each liter 154, ringer lactate 131, half normal saline 77 millimole sodium, 2/3, 1/3 have 51 millimole sodium chloride in a third, and 2/3 is 5% dextrose with 0 salt, 3% saline, 514 millimole. And this again, another table for clarification the component of each type of IV fluid. Post-kidney transplant, this makes me cry. Post-operative day 0, patient, his body weight is around 80 kilograms, blood pressure 140/80. Post-operative day 1, 82 kilograms, blood pressure increased. And the post-operative day 2, 84 kilograms, blood pressure more increased. Started on antihypertensive for his blood pressure. And the post-operative day 3, body weight around 87 kilograms, blood pressure 151/87. With 7 liter, and the patient discharged 90 kilograms, blood pressure like that, with 10 liter, urine output decreasing with azotemia and uremia. What difference between azotemia and uremia? Azotemia just high BUN without any uremic symptoms, but uremia is high BUN with uremic symptoms. And this patient ended by dialysis. This is by our mistake. This is our iatrogenic. You should cry for that if you found this target weight increase, blood pressure increase, target weight increase, blood pressure increase, target weight increase, and you give an antihypertensive. Please don't give any fluid here. Just give Lasix for your patient, and the patient will be okay after that. The kidney. With me, I'm crying, Dr. Karim said, and this kidney will ask for help. Please help me. Please give me Lasix, please. Kidney, don't suffocate me. Don't give more fluid. You are giving fluid to the heart, and this will end by congestion here and the venous congestion. And this will end by compromise the circulation and perfusion to your kidney, and the kidney will be stuck. Loading fluid volume in the heart, increase the hypervolemia, IV fluid infusion here, increase the load in the heart, renal vein congestion, suffocation, delayed graft function. And this will end by volume overload, discologging, and calling for dialysis, because the patient now is already blocked from congestion and decreased perfusion to the kidney. You need dialysis to remove the fluid. Hemodynamic assessment post kidney transplant oliguria, just ideally by CVB, central venous pressure, blood pressure, edema, pro-BNP. You should check all this for any patient with oliguria post kidney transplant. CVB, blood pressure, edema, pre-natriuretic peptide, beta-natriuretic peptide for volume overload or heart failure. Hypovolemia, just to give 250 normal saline challenge. If a patient EU or hypervolemic, just irrigate your folic acid. And then persistence oliguria, ultrasound, renal scan with good flow, this delayed graft function, no flow, consider surgical exploration. يبقى دي hemodynamic assessment post kidney transplant. If the patient with oliguria, check CBP if it's low or blood pressure is low or edema or no or beta natriuretic peptide. If the patient hypovolemia, give challenge 250 normal saline. If you hypervolemia, just check your folic acid by irrigation. If persistence oliguria after all that, ultrasound Doppler scan. If no flow, consider surgical exploration of good flow plus or minus delayed graft function. Early progression of diet, post-operative day 0, day 1, day 2. Post-operative day 0, assess bowel motion or bowel sound by a responsible nurse or nurse taking care, and start sips of water. Once the bowel sound present, advance to clear fluid if no nausea or vomiting. Post-operative day 1, this day of surgery, and the day 1 at morning, just a clear fluid if no nausea or vomiting, start to diet as tolerated, maybe full fluid. Full fluid means, clear fluid means just a clear water, and full fluid maybe some electrolytes like juice, and then advance it to diet as tolerated if no nausea or vomiting. Post-operative day 2, should the patient taking full diet. Please don't delay diet until the patient pass flatus or a stool like that. If you have bowel sound, just start, because this patient, this surgery already retroperitoneum, not inside the peritoneum already. This is the most important home message. And this daily requirement for regular diet, this calories around 1,600 to 1,900 kilocalories, around in patient with 60-70 and also a 60 to 70 gram protein daily. This is regular diet, and this is therapeutic, and they know this in ICU 25 to 30 kilocalorie per kg per day, with protein require 1.2, 1.5 per kg in acute phase post-transplant. And to avoid, this is a consequence of fluid overload, this will GIT edema, malabsorption, and ileus already from volume overload. This is other complication. We have many complication of volume overload: cerebral edema, myocardial edema, pulmonary edema, renal interstitial edema. And if renal congestion happen, will reduce the renal blood flow, increase interstitial pressure, reduce the GFR, and will end by uremia and salt and water retention. And the hepatic congestion also impair the synthetic function and cholestasis, and GIT edema will end by no flatus, no bowel motion from decreased malabsorption and ileus, and the tissue edema, poor wound healing, wound infection, pressure ulceration. This is a consequence of volume overload or more boluses of fluid. And this just also for a diet, no need to go more details. Early mobilizations is the most important topic to enhance recovery after surgery. Post-operative day 0, day 1, day 2, day 3. The post-operative day 0, the patient can sit 1 hour in a chair within after 6 hours from his surgery. He can sit 1 hour in a chair. Post-operative day 1, he can sit at least 4 hours, and the nurse assisted first to walk more than 20 meters. Pain medication may be given 30 minutes before. Hourly incentive spirometer to avoid any lung atelectasis. Post-operative day 2, at least 6 hours in a chair, more than 20 meter walk every 4 to 6 hours, at least twice per day. Post-operative day 3, walk 50 to 100 meters every 4 to 8 hours, at least thrice a day. Just don't forget all this. You should early mobilization for your patient from post-operative day 0. After 6 hours, the patient can sit 1 hour in his chair. Post-operative day 1, he should start to walk at least more than 20 meters with 4 hours on the chair, and will increase gradually from post-operative day 1. Transfer to general ward unless otherwise the patient and otherwise specified. Patient requires further monitoring. The patient can be transferred to general ward. Post-operative day 1 from ICU if no more monitoring needed for your patient. And this IV fluid, how to start, and 1 to 1 day 0, 1 to 0.5 half replacement on day 1. Early progression to diet from sips of water, clear fluid day 1, diet as tolerated in day 2. Early mobilization is chair, short walk, and then walk in day 2. And the location should be shifted to a day from day 1 to a regular ward. And you can, don't forget opioid use for pain, basiliximab or induction, whatever, FDK ultrasound, vascular access removal, urethral catheter removal by day 3 or day 5, according to the protocol here. Outpatient transplant team assignment, pharmacy teaching. You will start teaching from post-operative day 1 or day 2. Don't forget folic acid. Folic acid out by day 3, maximum day 4 or 5, except if urological complication or problem surgery during a surgery. Ask your responsible nurse to do a BDR to check residual urine every 4 hours for 2 times. If after removal of folic acid, if the BDR already less than 200, discontinue this screening for residual renal function by ultrasound. By Dr. Karim, those who understand shall alert others, spread the knowledge, and do no harm for your transplant. Please share to your colleague or friends and share the knowledge, and do no harm for your patient. Don't forget this, do no harm for your patient. واتمنى ان تكونوا استفدتوا ان شاء الله من المحاضره دي، ونسالكم الدعاء بالتوفيق والسداد والبركه في الصحه والمال والاهل والاولاد. ولا تنسوا دائما الصلاه والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. واترككم في رعايه الله وحفظه، والسلام عليكم ورحمه الله وبركاته.